Welcome to another episode of Beyond Risk and Back. Thank you for joining us. I appreciate you taking the time. If you're a brand new guest, thank you very much. We're coming on 5 years of this show. I'm really grateful that you have helped us with the amount of episodes, the downloads. Today's show, I'm very interested in because it really is talking about a double-edged sword. We're going to talk about ketamine. We're going to talk about I want to talk about this. I think we need to talk about this because this is something that many of us as adults, us Gen Xers, we heard of this being one thing. And now all of a sudden it's being talked about in another way. And I'm going to be honest, I drug my feet a little bit on this concept and on this conversation. And that goes a little against my nature of wanting to make sure that every tool available to adults who are struggling with their own mental health or addiction, or to children who are struggling with mental health and addiction, is talked about and is available. So I got yet another expert on this. However, I got a little bit more of a personal connection to this expert. My wife has actually seen who we affectionately call Dr. Koshal. This is Koshal Latifzai. He is there in Boulder at the Rocky Mountain Regenerative Medicine. It's his clinic there. And my wife did a ketamine treatment. And I was nervous. I was skeptical. Her experience taught me that there's more to this than I know. And I've done some interviews with other experts on ketamine and ibogaine and all these other types of things that maybe we should be nervous about it. Maybe we should be more courageous about this. But the one thing I do know, and the one thing we're going to ask Dr. Koshal about, how deeply should we be looking into this? Should you, as a parent, be looking into this for your teenager? Is ketamine okay? What is a K-hole? What does this mean that this has been abused as one thing and now being used as another? Can we make the transition safely? Are the laws in place to protect users? Are the laws in place to guide the doctors? So, Dr. Koshal, thank you so much for joining me on Beyond Risk and Back. Happy to have you here.
Thank you so much for having me, Aaron. It's a pleasure.
Well, I know we have been spending a little time trying to get together. I'm glad we finally have. I'm interested in the conversation. I've seen some great stuff about it. I've worked with children who have struggled with ketamine. And so I want to dig in with you. But first, why the heck do you do what you do, Doc? Give us the background. Where'd you come from and why are you doing this?
Yeah, well, just to keep it brief, I grew up in Kansas City, Missouri. I went to medical school in New Hampshire, Dartmouth Medical School. And after I graduated, I went to Yale University for emergency medicine training. So I was an ER doc. After I graduated, I met my wife while I was at Yale. And then we moved to Colorado in 2013, and I started work as an ER doctor. And I did that for several years before myself and the other physician, who also is one of the owners here at Rocky Mountain Regenerative Medicine, decided to start our own clinic. And there were certain things about conventional medicine that I think really turned us off that I don't necessarily, want to talk about and detract from our discussion here. But we started this clinic to bring about a way of helping our patients sort of stay out of the hospital. And a big component of that is empowering their biology to heal itself. And we do that several different ways. But as a part of that, we started incorporating ketamine to augment mental health, to treat things like depression, anxiety, various addictions, alcohol, opiates, et cetera, et cetera. And so we've been using ketamine here at our clinic in a way that's very much different than how we used it in the ER. In the ER, when we were resetting fractures or cleaning up really complex wounds and repairing them, we were using ketamine more for its anesthetic effects. And that's how really ketamine first started being used in the 1960s. But slowly over time, people became more aware of its antidepressant, anxiolytic effects. And it's sort of taken on a life of its own in conventional medicine. And that's, how we started using it in our clinic more for its mental health benefits. And so we've since treated hundreds of patients, and I can share our experience with regards to ketamine with you. So,
Well, my first curiosity is why in your clinic did you and this other doctor make the leap from being an MD into working with people with mental health? That's not generally, uh, and I think we would all agree that we would like medical doctors to be more educated around mental health issues. But why did you take that on? Why would you take that on? And supplemental training, how did you decide that you were ready to step into the mental health arena armed with what you guys are doing?
great. That's a very good question. So, and you raise a really good point. So, the primary objective at our clinic is not just to cater to mental health issues, where, regenerative medicine is this new field of medicine compared to, say, surgery or endocrinology or gastroenterology. Regenerative medicine is a field of medicine that really tries to emphasize, again, using the person's own biology, because it turns out that a lot of things that we do in medicine interferes with these natural tendencies that we have as biological creatures of self-repair and self-regeneration. And so in the ER, at least, we would see the same patients over and over again. And a very good example, a common example, are diabetics who maybe weren't taking their medications, and they would come to us in a state where they're very ill, and we would admit them to the hospital. They'd be hospitalized for, say, a week, and they ended up getting discharged only to be re-seen a few months later in sort of the same state of extreme sickness. And we had to sort of discover a way to stop those patients from coming back to the ER. Sort of the answer for us revolved around some of the things that we'd like to think we're doing in medicine, but we're not. And sort of things have deviated to a point where the patient comes into the hospital almost expecting a quick fix. And as doctors, we'd like to pat ourselves on the back by providing that quick fix. But the reality is that the quick fixes are just temporizing measure, as the name would suggest. I mean, what we need is to sit down with those patients, spend quite a bit of time with them, explain to them, some of the things that they can institute as long-term repairs for whatever the ailment is that caused them to come back to the hospital. Those are solutions that de-emphasize use of medications or surgical interventions. And in terms of mental health, like, I can't tell you how many people in the ER would show up in a really psychotic state. Maybe they were suicidal. The family's at their wits' end, and they want help in that immediate setting. And sometimes you would have the patient wait for 3 days on a mental health hold while you were tracking down a mental health specialist to come in and take a look. And then the end result of that was they would get admitted to a facility, an inpatient facility. And sometimes you would get feedback from the patient's family because the patient was back a few months later. And it turned out that their experience was really poor at that facility. They didn't get the attention that they needed. They ended up getting placed on various antipsychotics, antidepressants, anti-anxiety medications, and it was a quick fix. They ended up getting lost to follow-up. And the sense that we got from those patients and their families is that they were sort of throwing in the towel. They didn't know what else to do other than come to the ER, wait for 3 days, only to not be given a good answer, a satisfactory answer. That was one of the reasons that we started looking at other modalities that we could incorporate in our clinic. That is, we do a lot of things here. We do stem cell therapy for orthopedic reasons. We do hormone replacement therapy. So we do a lot of therapies that fall outside of purely mental health issues. Certainly, ketamine was something that we gravitated towards because the research that we looked at cited results that were much better compared to conventional antidepressants and anti-anxiety, antipsychotic medications. And I can go into more detail about that, but ketamine is not a quick fix. You can't, just like Tylenol doesn't have a batting average of 100, this ketamine also doesn't have that, but it certainly does better. It outperforms some of these more conventional SSRIs, for example. And so that was something that we gravitated towards.
How did we discover this? And you brought up a lot of really interesting points that I want to cover, but how did we discover that this anesthesia was suddenly helping people with depression and anxiety? How did that even come about?
That's a really good question. So, ketamine was developed in the 1960s, and it was developed to replace another anesthetic that did a pretty good job in terms of providing anesthesia, but it turned out that there were a lot of psychological side effects that were less than ideal. And that other anesthetic that ketamine ended up replacing is phencyclidine, aka PCP, or angel dust. So PCP was devised in the 50s, but it really fell out of favor because of those psychological effects. And so ketamine was designed to work very similar to PCP, but it was less potent. And the hope was to avoid some of the psychological adverse effects while still taking advantage of its anesthetic effects. It started being used in anesthetic procedures. It did a great job of that. But what ended up happening is some of these patients who would wake up from their anesthesia, they would report this out of body experience that they were undergoing or they had undergone while they were receiving ketamine. And so that was something that was very reminiscent of PCP. And so researchers were very cautious to those towards those side effects. Ketamine is still in use even today. Like I said, in the ER, there's certain advantages that ketamine provides as an anesthetic that other drugs lack. So, for example, things like opiates or benzodiazepines or propofol, these are all anesthetics, but one of their common side effects is that they reduce the respiratory drive. And if somebody is not intubated, they don't have a tube down their throat, they're not on mechanical ventilation, you want to sort of preserve their respiratory drive. If somebody is involved in a trauma and there's a lot of blood loss, having a patient drop their blood pressure is less than ideal. But it turns out propofol, opiates, benzodiazepines can decrease your blood pressure and risk an untoward outcome. Ketamine doesn't do that. Ketamine can be administered in a variety of ways. It can be given intravenously or IV. It can be given intramuscularly, which we've done before for these trauma cases, and it's absorbed fairly decently. It can be given orally, it can be given intranasally, it can be given sublingually. So there's a lot of variety with how ketamine can be administered that some of the other traditional anesthetics, they don't have the same advantage. And so in the 1960s, the Vietnam War was underway. And so ketamine was used pretty extensively in that context. And then afterwards, it turned out that a lot of those soldiers had fewer instances of PTSD, of depression and anxiety, some of the things that other soldiers were experiencing at a higher rate. And so slowly, it started to be studied in the context of mental health. And there was a study in 2000 out of Yale that really highlighted that even a single dose of ketamine as an infusion can help treat what's referred to as treatment-resistant depression. And there's different definitions for that term, but the bottom line is these were patients who had failed a multitude of other therapies, and so they ended up taking ketamine really when their symptoms were so severe that they were suicidal. And it's not like one infusion of ketamine did the trick and turned everything around, but at least for the next several days, their symptoms were much more manageable. And so since then, a bunch of other studies have been published looking at the utility of ketamine in the context of not just depression, but anxiety and various types of addictions. And again, the success rate is variable, but it's higher than some of the more conventional therapies.
You talked about ketamine not being a quick fix. Is the idea that a quick fix is desirable? Is that the medical industry's fault, doctor's fault, or patient's fault?
Well, I think it's a combination. It's a combination of those things. Unfortunately, the way our medical system is designed is very reactionary. You wait until something breaks down and then you look to fix it. And you want a quick fix. That's just the way we're sort of programmed. And we're not, it's a medical system that's not designed to optimize biology. In other words, if nothing is wrong with you, right? If nothing is wrong with you, you almost regard it as a drag to go to your primary doctor once a year for health optimization. And even then, the answers that we're giving you as primary doctors, right? They're designed to put out fires. In other words, if you come to me for a once a year annual physical, and I do that physical, and I get a bunch of labs, and there's nothing highlighted in red, there's nothing that has an H or an L next to it for high or low, we probably don't have much of a discussion. And so we don't, in other words, put much value on optimizing people's health. And so when things do break down, that's when you go see a doctor. When things do break down, that's when you anticipate, a quick fix. And so I think, to your question, a lot of it is us doctors driving that mentality for a quick fix, and a lot of it is what the patient expects. But at the end of the day, whether it's us, whether it's patients, that's just the way that the medical system is designed, unfortunately. So
What is ketamine doing in the brain? And this is important because a lot of parents come here for moral support and for a community and for information. And what they go home with, in addition to receiving those things, is they go home with an understanding that whether it's mental health, addiction, depression, anxiety, self-harm, running away, we are dealing with brain chemistry issues. And when we're talking about something you've said since the very beginning, this regenerative medicine, this getting the body to the body's own biology to start working in favor. So much of my audience is here because we feel like our children's brain chemistry or brains or bodies has hijacked our entire family. So now what is happening with ketamine? What is it in my brain that changes that as a parent, I should look to this either for myself or for my teenager going through depression, anxiety, just struggling with stuff? How's it changing the stuff upstairs? What's going on in my attic?
there's a lot of things that ketamine does. A lot of it we don't understand. A lot of it we don't understand. But here's what we know. Unlike, say, opiates hit a very specific receptor in the brain referred to as the mu receptor. Benzodiazepines, they land on a very specific receptor in the brain called the GABA receptor. Ketamine is somewhat unique in that it interacts with several different receptors to bring about the effect that it does. So, for example, it does touch on the mu receptor that opiates also hit. It does land on the GABA receptor, which is the purview in large part of benzodiazepines and alcohol, for example. But some of its effects we know are due to ketamine's interaction with the N-methyl D-aspartate receptor, also referred to as the NMDA receptor. And specifically, the NMDA receptor that ketamine interacts with are located on inhibitory neurons. So these are the off switches for other neurons. And in blocking those receptors, it turns the off switch, these inhibitory neurons, it turns them off. So, we commonly think of certain medications or drugs as uppers or downers. So ketamine in that sense is an upper. By turning the off switch off, by blocking the NMDA receptors located on inhibitory neurons, it turns them off. And so you enter this state of excitation in large part. So at lower doses, ketamine can cause stimulant-like effects. And as you dial up the dose, people start to experience distortions of their perception, and they can enter and start to experience a floating sensation, which is something that's very commonly experienced. If you keep dialing up the dose, you start to experience hallucinations, and even at its extreme, catatonia. For example, if we're going to use it for an anesthetic procedure, you might give a certain dose really, really quickly to that patient. And in doing that, you go through those phases really fast, and they enter a state of catatonia where their memory is impacted, their perception of pain is impacted, and you can expose those individuals to painful procedures, orthopedic manipulations, for example. And once they wake up, they're not going to have any memory of it. So those are some of the effects that we know ketamine brings about. Again, it interacts with a bunch of different receptors: the mu, the GABA, the serotonin receptor, which we really didn't discuss, but that's a receptor that LSD or psilocybin also interacts with. Ketamine also interacts with the same serotonin receptor. But the most important, the most well-established means by which ketamine brings about its effects is by blocking the NMD receptor on inhibitory neurons. But here's the thing. I told you that the anesthetic effects of ketamine were what was discovered initially, and that's what I just described to you. Its mechanism of action with respect to bringing about those acute phase symptoms. But these long-term effects, these antidepressant, anti-anxiety, anti-addiction effects are brought about somewhat differently. And to explain that, I should first explain that as humans, as biological creatures, we're sort of programmed to reinforce the neurons that we use most commonly. So, for example, imagine yourself as an athlete, a tennis player, for example. The more you practice, the more you're out there on the court, swinging the racket, getting coached, those same neural pathways get reinforced. The same neurons that fire together, they get reinforced to do just that, fire together over and over again, to such an extent that you don't have to think about it. It just sort of happens. And there's this concept, and I'm not sure if you're familiar with it or you've heard of it. It's called a default mode network. And what that is that same thing that I just described to you happening when your brain is at rest. You might also describe it as rumination. So, and that's a concept that's really important for somebody who's depressed, for somebody who's anxious. They're ruminating with those same thoughts. So similar to that tennis player who's practicing hours and hours and hours, a person with depression, a person with addiction, with anxiety is practicing that over and over and over again in their mind, in those same pathways, those same neural networks are reinforced to such an extent that it becomes their default. And that's the stuff that's happening in the background, regardless of whether they're out with friends at a bar, regardless if they're at work. That's the background noise that is happening, not unlike the athlete's scenario that I just kind of painted you.
At brabapp.com, parents, I have posted a parenting masterclass. Before you fast forward through this commercial, give me a chance, because I'm going to keep it short. I'm going to keep it blunt. This is a Telly award-winning parenting masterclass. The content is everything I have ever taught a parent in the past 20 years of working with parents in crisis. There are 3 components to the course. 56 classes in 3 components. The red, the beyond risk, the crisis children. Yellow, the at-risk children. And green, when things are going well, how do we get them to go great or keep them going well? It's everything I've ever taught a parent in 20 years of working with families. But here's the deal. It's $99. I want every parent to be able to have access to this course. So please go to brabapp.com, B-R-A-B for Beyond Risk and Back. brabapp.com, brabapp.com. Well, I think what you're saying, and it makes so much sense. It's what you focus on expands. Now, as parents, when your kid is depressed, when your kid is anxious, you're trying to shake them out of the conditioning, habituated rumination, this spin that they're in. And we talk about it. Oh, they're spiraling down. They're winding themselves up. And someone who doesn't struggle with anxiety, someone who doesn't struggle with depression, it looks like you're self-indulgently focusing on the fact that you're depressed. But we're also talking that the brain chemistry is keeping us in this place. Nobody's choosing this.
That's I mean 100%. 100%, Aaron. I think you hit it right on the head. We have, one of the things that ketamine does in kind of shaking you loose, breaking you out of this default mode, right, is by increasing the concentration of a couple of chemicals in the brain. One of them is abbreviated BDNF, and the other one is abbreviated VEGF. So BDNF stands for brain-derived neurotrophic factor. There was a time when we used to think in medicine that the brain that that's matured by age 3 is the brain that you're going to have for the rest of your life, and there's no more neurons being developed. There's no more connections that are happening. But that's really changed over the past 15 years or so. And it turns out one of the chemicals in the brain that's really critical for that is BDNF, brain-derived neurotrophic factors. What BDNF does is it encourages formation of new connections between nerves. We refer to those as synapses. So on the one hand, BDNF increases new connections between nerves, and there's really elegant experiments that people have done in a lab where they've taken the fluorescence from the gene that causes fluorescence in lightning bugs, right? They've taken those and put them in these nerves, and so they light up under the microscope with a dark background, and they've bathed those nerves in BDNF. And sure enough, you can see these tentacles spread out from these nerves and start to interact with one another by forming new synapses. And that's what's happening in our brain when you increase the amount of BDNF. The other thing that BDNF does is it does encourage formation of actual new nerves. It gives rise to formation of new neurons. And the reason that's important is it allows for the potential for that individual to break out of that default mode network. In other words, by the same trigger that causes depression, same trigger environmental stimulus for resulting in anxiety, by increasing new formation of new nerves, new connections, you're allowing that individual to perceive the same event in a new light, where it's not triggering depression, it's not triggering PTSD, et cetera, et cetera. You're allowing for the potential for that individual to interpret the same trigger under a new light. Does that make sense?
Yeah, it totally does. In our treatment center, we use low-dose naltrexone therapy. And for adults who know about naltrexone therapy, in high dose, it's used for opioid addiction, heroin addiction. Low dose, it was a dopamine inhibitor. Now, for kids who self-harm, that makes it seem like, why would you inhibit their production of dopamine? But when you use low-dose naltrexone therapy, and it essentially blocked the production of it, the brain kicked into high gear and produced more. More to a person who doesn't produce enough is the right amount. And so it just seems like we're saying that when we introduce ketamine to the brain, new synapses, new neurons are stimulated. And so you're talking about reframing events. You're talking about somebody being able to talk about an event that causes trauma and triggers, and suddenly they're not being triggered in trauma because their brain has grown new parts. Is it this simple? Is it okay? Well, no, let's actually jump into, now that we've got kind of the basic science behind it. And I know we're dealing with one of the most complex organisms on the planet, which is the developing brain. Like, so this could go a million places. When should a parent call you? When should a parent be thinking about this for their kid? When do they need to get over well, I thought ketamine, I mean, he had abused ketamine once. Now I should go give it to him. When should a parent cross over that threshold?
Yeah, I mean, I think you bring up a really good point. You know, the same thing that can be interpreted as some of the strengths of ketamine is also its weakness. So, for example, earlier I said one of the advantages of ketamine over other anesthetics is the variety in which it can be administered orally, sublingually, intramuscularly, intravenously. We're to the point now where I read a story recently, I think it was in the New York Times, where ketamine was being dispensed through these companies that you could download an app and maybe a doctor talks to you and there's an intake of some sort. And then you get your ketamine in the mail. And it turned out that some of these patients were not responding well to it. And some of them were suicidal, for example, and they couldn't access help through that app. And so part of it was, criticism of the app, but I think part of it was also a criticism of ketamine, rightly so. I mean, look, just to give you an idea, if somebody comes in and we're giving them IV ketamine, maybe we're giving them 50 milligrams, maybe 100 milligrams. When you read these stories of how ketamine is being abused, they're using grams and grams of this stuff, and ketamine can certainly be abused. There's the initial story, and I'm blanking on the researcher's name. I think he worked for Eli Lilly. He's based in California. I'm totally forgetting the name, and if somebody mentions it after the podcast, I'm going to remember. But he did some of the initial experiments as far as ketamine was concerned, and he was experimenting on himself. And he wrote a book about it. I think it's called The Scientist is the name of the book. And at some point, he basically has an IV in his arm and he's getting like a 24-hour infusion of this stuff. And he's at a point where he's delusional. He's having hallucinations, thinking that he's in some sort of a computer game and he needs to report this to the president of the US. So he's completely delusional. There was another famous author who was using ketamine at pretty consistently on a daily basis, administered intravenously, and she ended up freezing to death because even though ketamine itself doesn't have what's called an LD50, the dose at which death results in half of in 50% of individuals who take that dose, ketamine doesn't have an LD50 similar to, say, Dilaudid or fentanyl, for example. You can certainly abuse it and you can certainly die from something like that where it alters your sensorium to such an extent that you go outside completely oblivious to the fact that the weather is freezing and you can potentially freeze to death. So there's certainly a potential for abuse. There's certainly a potential for harmful things to result. And I think one of the things that make that really easy is the fact that you can take ketamine orally. It is the fact that you can take it intranasally, especially for individuals who already are pre-programmed for some sort of an addiction, be it from various social stressors, or maybe they're already addicted to opiates or alcohol. They certainly have the potential for that addiction to ketamine as well, because they have that quote unquote addictive personality, right? And so you can abuse something that's readily accessible, that allows you to have this high, this out of body experience. And so you can certainly get hooked on ketamine. And one of the ways we address that at our clinic is that we try to administer ketamine intravenously. There was one patient who was insistent, a couple of patients who were insistent on getting ketamine intranasally. And that's, we sort of draw the line there. And again, the reason is if they have something that's accessible to them, especially if there's other confluence of factors that make addiction likely, right, or possible, then we don't want to take that risk at all. And we just want to administer it intravenously in a controlled setting. What I recommend to patients is to undergo 6 infusions over the course of 6 weeks to give it a good try to work. And then you have to give it time. A lot of the changes that ketamine brings about are biological changes. And those things won't happen overnight. They can take weeks and weeks. And so what I tell patients is try it 6 times, once a week, and then rest, and then give it a break. Do it in conjunction with other treatment modalities, other therapies, whether that's cognitive behavior therapy, other forms of talk therapy, whatever it is. Don't just do ketamine in isolation. Incorporate it into other forms of therapies that'll augment its effectiveness. And then give it some time and come back. I have patients who will come back once a month. I have patients who will come back once a year. I have patients that won't come back after 6 sessions. Maybe the ketamine didn't work for them. And for 25% of individuals, it doesn't do a whole lot. And that's in line with other studies that are out there. About 25% of the time, it doesn't do anything. But if it works for them, just kind of try to spread out those therapies as much as possible. Try to go as long as you can without a ketamine infusion. And like I said, for some patients, that translates into once a month. For other patients, it's once a year. And I think that's a good medium. A lot of the research studies around ketamine that are out there, they endorse a similar sort of timeline. In the U.S., and it's not like this elsewhere. The UK is a good example. In the UK, they have a national health system, NHS, that will administer ketamine for some of the things that we've been talking about. But in the US, ketamine clinics are very, very common. And some of those clinics, they don't have a physician on site. And so you go in, maybe there's some sort of an initial form that you complete, you get evaluated by a nurse or a nurse practitioner or a physician's assistant. And then next thing you know, you're getting the same dose of ketamine intramuscularly, usually. And then the room has to be turned over, in an hour and 90 minutes, and you're sort of shown the door. And that's probably the wrong way of doing it. There's some positives that can come from having a bunch of these types of clinics out there. But I think by and large, the way that we're doing ketamine in this country is probably a little cavalier, certainly compared to the UK model. In my opinion, the UK model is way too conservative and it's going to impede innovation. But the way that I think we're doing it here, where there's a bunch of clinics and there's no central repository of how that data is then submitted and reviewed to see what works, what doesn't work, that I don't think that's the right answer either. I think if you're going to go to a ketamine clinic, there should be a physician on site. I think there should be realistic expectations. I think it should be incorporated with other forms of therapy. Here we do have a specialist who will come in if the patient wants to work with them, who will talk them through that journey of while they're on ketamine to try to explore things that they, somebody with PTSD, for example, you can imagine that they'd be afraid of exploring certain things that bring about a lot of extremis, mental anguish to them. Ketamine allows you to explore those little crevices that are hard to go into when you're not under the influence of some sort of a psychedelic like ketamine, for example. So if I think ideally, the ideal ketamine clinic, if you want to call it that, we're not a ketamine clinic. I want to be clear on that. It should be a place where they would welcome, a therapist coming in. A lot of our patients, I encourage them to journal, even though while they're under the influence of ketamine, they may not have the dexterity to write down every single thought that they have. But even if it's like a sentence, 3-4 words that they can look back on hours later, days later, with that puts their situation in a new context. I think it's helpful in terms of then addressing those things with their therapist at a later date and start to make improvement. It turns out that the effects of ketamine, they don't just end when the infusion ends. They can continue on for days. And so if you can look back at some notes that kind of jog your memory as far as what you were thinking, what you were exploring, I think that's really helpful.
My wife's experience was very positive that she had at your clinic. And, she was dealing with a lot of stress and even a little bit of low depression. It was very situational. This had all come after dealing with the closure of our facility and how, the insurance companies we felt like we were sabotaged by property insurance of all things. But nonetheless, it had really hit her hard. She had put her whole heart and soul into the work. And I remember when we were there, I can't remember whether it was you or someone else, but as she was relaying her experience, I think it was one of the nurses who asked me if I was interested and in seeing. And I was an immediate no, but I also know myself. And I will say the whomever it was very respectful of my response. They didn't push it. They didn't. And I have had people try to desperately sell me on an ayahuasca journey. So, oh, it'll cure your addiction. It will do all this. And first of all, the people who are saying that don't know shit. And if I heard a doctor say that, I would have a lot of what I believe are intelligent questions. But when I hear it from just somebody else who's done it, I don't really give that much credit. But I have had people desperately try to sell me on a concept that would cure my addiction. And there are a lot of us in the world of recovery, and I've been sober 25 years, that we know our bodies and we understand addiction. And I would like to think that I do more than others because I have worked in the industry of addiction and mental health very, very closely with addicts and people who struggle with mental health. So not being sold on it at your clinic, with other people, it's felt like a timeshare, for crying out loud. Like I can't leave without deciding to try it. I didn't get that from your team at all, number one. And number two, what does that mean to you when I say to you, as a person in long-term recovery, I know myself from what my wife described, I would love to do it. And I'd probably have a hard time stopping at one. Would you agree with me, or would you say, here's what's really going on?
I think people who have that recommendation are obviously well intentioned. You go through these as a people. We go through these phases where different things are in mode. A diet is the common example where people, meanwhile, maybe they had a great experience on the ketogenic diet. And part of the advantages of being a doctor is that you can actually not just look at research and appreciate the fact that research primarily applies to populations, not to the individual. The individual experience might be quite different, and I think that's something that we lose sight of. Even as doctors, we lose sight of that. But as a doctor, I have the advantage of actually checking my biomarkers. So if I'm going to institute, say, the ketogenic diet or another extreme diet, I can check my biomarkers and see where I am. And it turns out when I did the ketogenic diet and I made sure that I was in ketosis by checking my ketone levels, my biomarkers were terrible. But not everyone is like that. I know plenty of patients who are doing the ketogenic diet, and their biomarkers are something to envy, but my body is not designed like theirs. And so, although ketamine certainly has a much higher success rate compared to other conventional antidepressants, SSRIs, or benzodiazepines for anxiety or whatnot, it doesn't work for everybody. And I can tell you that ketamine, it's certainly, it's difficult to benchmark ketamine against other addictive medications and drugs like narcotics or alcohol or what have you, benzodiazepines. It's difficult, but I can tell you that ketamine is less addictive. Have people abused it? Absolutely. Have people been addicted to it? Absolutely. And so if you have that frame of mind where you know your tendencies, and if you think it's going to lead to you being addicted to ketamine, then don't do it, because yes, it will, through its interaction on the NMDA receptor, it will get you high. And I don't know what it feels like to get high on narcotics or benzos. And I've certainly read those effects, but it's not the same as taking it. It's not having that warm feeling of taking it, that comfort, that all those social factors that security blanket that goes into it. So I have no idea when somebody's telling me about their interaction with addiction in general. You know what I mean? Like I can't relate to them one to one. And so if you think that ketamine is not for you, I think you made the right decision. It's probably not for you. And I certainly have had patients who come in and be given ketamine for mental optimization. In other words, they don't have addiction. Maybe they have a worry, they have an anxiety. They want to promote, a new way of thinking about a certain problem at work. And these are high-powered CEOs, and we'll do ketamine for them for that specific reason, and that's a totally different approach than, again, conventional medicine, where something has to be broken in order for you to fix it. These are people who are coming in, and they don't take on addiction to ketamine, but everybody's biology is different, and ketamine, I can tell you, it doesn't work for everybody in terms of relieving their depression symptoms, their anxiety, their PTSD. I wish it did, because it would, it would bring me a lot of joy seeing patients improve. But I can tell you, a quarter of the patients, even after doing 6 sessions per week of ketamine, me adjusting their dose in a way that I think is appropriate, it turns out it provides maybe temporary relief, but not full relief, not long lasting relief. And for other people, it doesn't work at all. It's another, arrow in the quiver, but it's not it's not the arrow. There's other therapies that also help depression, like electroconvulsive therapy, for example. It turns out it works a lot better than SSRIs. It works a lot better, but it's not considered first line. First line are medications that, in my opinion, shouldn't be first line.
That's been a very interesting thing, watching, for lack of the better terms that we have, shock therapy come back, and because it was so stigmatized, and now the research behind it is like, no, we're better at this now, and it's very effective. I have a wrap up question for you here, and I will tell you the biggest thing that I knew, my biggest trigger when my wife was talking about her experience, was that I was jealous. That's how I knew I needed to just stay away from it, because that's where, if already my response is an emotional, desirous, covetous, greed, envy, I'm already in the den of sin, and I just need to stay out of that pit because I know what happens when I'm there. All of this being said, all the information you've given us, I know my parents are listening to this show and saying, okay, if I'm going to ask about this for me or for my kiddo, what are 3 to 5 questions I should come ready to ask so that I know I'm getting a provider who's going to really see me through this process, not just say, "Oh, I can bill this," or "Oh, I can cash, I can cash charge this one." What should my parents be asking when they ask about ketamine?
I think there needs to be a physician on site, and the reason is ketamine is not risk free. So, for example, when you're infusing ketamine into somebody during the time,
You mean, I just want to clarify, you mean the physician is on site during treatment or for the entire process?
no, during the treatment, if they're like, they don't have to be in the room necessarily, because a lot of times patients want to be left alone with their thoughts, to journal, with their music, whatever they want, and you don't want to necessarily interfere with that. But one of the side effects of ketamine, again, in a trauma situation, it's helpful because it causes an elevation in blood pressure while it's infusing. And that's great if you're dealing with a trauma patient on an ambulance or in a helicopter. It's not such a good thing when you have a 90-year-old who already has hypertension, and you're jacking up their blood pressure even higher. And so it causes nausea. You want a physician there to be able to address that. There are other long-term side effects that, if you do ketamine the wrong way, it can be a real problem. One of them is bladder toxicity. where it injures the bladder to such an extent that the person is not able to void correctly, and that's a long-term effect. It can cause short-term memory issues. Again, if it's used incorrectly. So you do want it is a drug. You want a physician there on site. You don't want it to just be a nurse who's jabbing you with ketamine into a muscle and then coming back sometime later and they're asking for a thumbs up or a thumbs down, whether you want more or not, or if you're good. I don't think that's the appropriate way to do it. You want a facility that's open to incorporating your therapist or your family members, if you as the patient deem that to be necessary. You want that flexibility. You want a facility that is not a sort of conventional ketamine clinic that whose job is to just turn over the room, right? Where you get the ketamine and then an hour later or 90 minutes later, they have to bring in another patient into that room and they want you out of there because it kind of ruins the experience. You're at a vulnerable time when you can really use that time to think about and grapple with some of the problems that you're grappling with. And you don't want that disrupted because somebody wants, there's another patient scheduled to come into that same room. Most of the research around ketamine has been around its IV administration. And although the oral form, the sublingual form, the intranasal form, they're certainly more convenient. But again, those are the modalities of administration that have a high potential for abuse, especially under the right social circumstances. You don't want somebody addicted to those medications. And so the IV administration, you have much more control over it. So in other words, if I administer a drug to you intramuscularly, that dose is now in. There's no way to take that back. And so if you're experiencing a quote unquote bad trip, there's no way to reverse that. But if you administer it intravenously and you show the patient how to speed up, how to slow down the infusion, they have much more control over their experience. And so I think you'd be best served at a facility that administers it intravenously. There's a physician on site. They check your vital signs. In my opinion, ketamine should probably not be given intraorally, sublingually, intranasally, because there is a high degree of potential for abuse. And so those are the factors that I think I would be mindful. And more importantly, there was a lot of these studies around ketamine, they try to isolate the effect of ketamine versus other antidepressants. And so a lot of these studies, as inclusion criteria, they require that participants stop their SSRIs, for example, so that way they can really isolate what ketamine is doing versus what's on. And some of these clinics, they'll ask patients to stop their antidepressants before coming in. And I think that's risky. I don't think patients should be asked to stop. That there are studies out there that say SSRIs and other antidepressants play well, so to speak, with ketamine. So there's really no reason to stop those unless a clinician is just misinterpreting some of these studies and they take comfort in knowing that their patients have stopped their antidepressant prior to starting ketamine. So I don't think those extreme measures are necessary. And so these are all things to keep in mind when you're looking for a place where your parents, for example, could undergo ketamine therapy.
Dr. Koshal, how are my listeners going to follow up just to learn more about you, your clinic, and just to get to know you more as they've listened to the info in the show?
Yeah, we're located in Boulder, Colorado, and our website URL is rmrm.com. If you go there, you can see all the various other things that we do. Ketamine is in there, and I'm pretty sure we wrote a blurb about it. But most of our website is focused on, other regenerative therapies like stem cell therapy and hormone therapy, et cetera, et cetera. But there's certainly information there about ketamine as well.
I think that as we listen to Dr. Koshal talk about this, again, it just tells me as a podcast host who's trying to provide as much information as possible is that there's always more to learn. There's always, I like what he said about the arrows in the quiver. and that ketamine, like every other arrow in the quiver, is not that black arrow that's going to take down Smog. For all of you Lord of the Ring Hobbit fans, you know what I'm talking about. This is not the magic bullet, but it is another weapon that we can use against our depression and anxiety, our children's depression and anxiety. And really what he said about the reframing, that it allows the brain to look at something that has triggered us from a different perspective. You guys, that's what therapy is trying to do. 9 months time, over 3 months time of daily therapeutic intervention. That is one of the reasons why I'm interested in talking to these experts about ketamine, is because it does in a relatively short time. And remember what he was saying, 6 infusions in 6 weeks to start, and then take a break and have these conversations with your doctor. Be seeing your therapist during this process. Do cognitive behavioral therapy, CBT. This is not a one-off. It's not a quick fix. And I think it's these quick fixes that may have gotten us into the problems in the first place. And to reiterate what he was saying, physician on site, be open to incorporate the therapist and the family. Don't go to the conventional clinics, get the personal care. The conventional places are just turning the rooms over. IV administration has the most research and control behind it. Make sure they're checking your vitals and stopping the meds before. Our Dr. Koshal had questions that's kind of risky. So check, double check, and triple check. Get a second opinion. Never be afraid to get a second opinion, even on this show. And I'm not here to endorse ketamine. I have seen it on both sides of the fence now. And I know when it was offered to me, my dragon showed right up and said, say yes. And that was the sign that I should say no. So do your due diligence, parents. We got a medical doctor talking to us about our brain chemistry. My emotional feeling, my emotions around my addiction and my recovery showed up over potentially my possible medical need. I may just have to go get my needs met a different way. But find out, because I have seen it work firsthand. I watched my wife's experience. I've watched some of her friends' experience. I'm interested if this is going to be something to look at more and more and more. I think we should look at everything, but I've told you that. Most of all, remember to take care of yourself first, your adult relationship second, and put your children third, because that's how we do our best work with our children. When our personal health is in place and our relationships, our adult relationships are in place, our support systems, then we'll give our kids our best. Huge thanks to Deepen Productions for producing this show and the awesome music. I will see you next week on Beyond Risk and Back.